Okay, whilst you guys are introducing yourself, for those of you that don't know me, my name is Tara Humphrey. I do run a consultancy called THC Primary Care, but my main job and where we provide consultancy is around the PCN manager role. And I also am a primary care network manager, and I've just kind of taken it upon myself to just try to share as many resources as possible to help primary care networks, and in particular the PCN manager role. And what we're doing at the moment is we've created a series called The Role of the PCN ... We've done the role of the PCN manager, the role of the PCN Clinical Director, the role of the PCN pharmacist, and now we are covering the role of the FCP. And I've asked Chris to join me because we worked together in Cranbrook. So I was with Cranbrook for 2 years. And Chris is part of the Pure Physio team and came in, and it was just absolutely excellent. And I think you guys came in under quite difficult circumstances. And one of the things we did was an educational session, which we'll talk about a little bit later. It's been really, really helpful. And I did think we've got some highs and lows to share, because I think it's really, really important that we provide a balanced view. But I have seen the role work really well if you can kind of get through the teething issues and if you communicate. And I know we all know this stuff. And I did say to Chris, we probably may not tell you anything that you don't know, but are you doing it? Are you practicing walking and talking it all of the time to make sure, I don't like calling the additional roles, but the additional roles have got clarity around what they're doing, and that they feel part of the network, part of the practices. So that is the goal of today's session. So Chris, if you could introduce yourself, that'd be fab.
Yeah, hi. So my name is Chris Hedges. I'm a first contact practitioner down in Norfolk on the eastern side of England. And I work for Pure Physiotherapy, who are a large sort of provider both to the NHS and privately. I've got a split role, so I work as the sort of clinical lead for part of our sports injuries clinic that we run, and I'm also an FCP team lead. So I spend the majority of my time sort of in primary care doing diagnostics. My background really, or where I've kind of come from to get here, I qualified in 2006 in Nottingham. And ended up coming back via a year of working selling mobile phones, because there was no jobs as physios in 2006. Back to the NNN in Norfolk, which is sort of a large district general hospital. Spent a couple of years there, learned lots of things about sort of inpatient management. But really and truly, my heart was set on working in sport, and there weren't the opportunities in the NHS. So I went and worked for my lifelong fan team. I've been a Norwich season ticket holder for the great majority of my life, and I went in there in 2009-10 and stayed there for just shy of 10 years, going through some wonderfully successful times, setting up essentially what was a brand new service in physiotherapy and in sort of football. So where things weren't particularly organised before 2009-10, we went through a massive sort of auditing and development system called the EPPP over sort of the next 5 to 10 years. Norwich achieved Cat 1 status. In our first year of that, we were the only team outside of Liverpool, Chelsea and Man City to win the FA Youth Cup in the 2010 to 2020 period. We were thankful to produce a lot of young lads through our academy who now play sort of elite and Premier League football. And I got to grace the hallowed turf of Carrow Road, a lifelong ambition for me, a number of times, which was great. I was also thankful to be involved in some good research on things like biobanding and sort of how we could make the challenges more fair for children in different stages of their development. And then I left in sort of 2018-19 because my wife's a GP and has a pretty busy life. And my life was pretty busy too, and we couldn't do that all around having our 2 children. So I moved out into private practice at a company called IPRS, and then was approached by Finn just before the pandemic started to come and do some of this FCP work, and eventually look to build a sports clinic. And that's really what I've been doing for the last couple of years. I've worked in 2 or 3 PCNs, but one mainly. And obviously I met Tara a few months ago whilst doing some work with Cranbrook. So that's kind of where we are, and that's me and where I've come from.
Okay, cool. I can see we've got some PCN managers and business managers on the call. So I thought it may just be helpful to share, why did Cranbrook go down the pure physiotherapy route? And we'd looked at all of the roles. We had looked at some of our population health data, and we'd also asked our practices, and we asked the GPs and said kind of which roles do we want to, explore and look to hire in. And lots of neighbouring networks had got first contact physios, and everybody's experience, whilst the models were slightly different, everybody had a relatively kind of good, most comments were quite positive. But we were very clear from the outset that we didn't want to employ, because we didn't have the kind of clinical supervision infrastructure in place. So no one was like an expert on FCP, and that there is this kind of educational roadmap, and that kind of scared everybody. So we kind
of, and a lot of us still does.
So, I mean, by good old fashioned social media, reached out. I don't know who reached out to who, but somehow I got in contact with Finn, who is the CEO and like founder of Pure, one of the co-founders of Pure Physio, and we had quite a few meetings. So initially, I met with Finn. I met with 3 providers. So I met with each of the providers to get my head around it. It's probably quite a long-winded way, but this is what we did. This is what I did, and then I went to I had 2 co-clinical directors and said, well, these were the options. They all seem really good. And I was able to get testimonials from each of the providers. And then the kind of CDs then chose, I think we kind of shortlisted 2. And then those providers came to our PCN board meeting. And I think Finn came twice. So it wasn't, we thought, we might come on to this, we were taking a very considered approach, and it was really important that we had a good relationship, like a good rapport with the provider we were choosing, and we chose Pure. So that's just a little bit of a background on kind of how we became working together. So one of the things, I mean, lots of people, and what I always want to know, like what works well in your experience, Chris, in working in, I know you've got one main PCN, but what typical principles work well when it comes to embedding the role of the FCP?
Yeah, so I think for me, we've got to understand where we've come from in primary care to get to why and what works well. So we're on a history where traditionally GPs have done everything within primary care, and they're very good at doing a wide range of things. And that probably for the 1990s and the early noughties worked really well. But healthcare needs have got far more complex in the last few years, and the strain and pull on general practice has got a lot more. The need for patients to be seen and the desire for patients to be seen has got a lot more. And so I think we also know that, and I'm married to a GP for full disclosure, so I've got a daily insight into what that's like, but there's not enough being trained and going down that path, and there's not enough being retained within the service for GP to continue the way it is. So the NHS's long-term plan was, and part of that was around sort of bridging that gap between primary and community care, and this came out sort of 2 or 3 years ago, and sort of making sure that we could give personalised care. And I think that's probably the most important reason why we've ended up where we've ended up. We needed to widen that skill set in primary care so that patients could access experts earlier in the pathway, rather than that typical wait to see an expert physio being 25 weeks. Why not make it a week or 2 weeks at the very, very most? And that's probably where we've ended up where we are. And we now know kind of what physios in primary care do over the last couple of years, working as FCPs, and it's all very much down that musculoskeletal line. So we know that usually around one in 3 to 1 in 4 of GP appointments is for something musculoskeletal. And if there aren't enough GPs or appointments and long wait for community services, something needed to change. And what the FCP pilot studies in 2016 demonstrated was fewer referrals for x-rays and scans. And we know that's a massive, massive burden of cost on the NHS, fewer prescriptions, fewer and more appropriate referrals into secondary care, because there's a higher conversion rate of those referrals ending up in some kind of intervention. So trying to streamline the pathway with musculoskeletal experts was really, really important. And if you've got the average cost of a GP appointment being £30, the average cost of an FCP appointment is significantly less than that. Plus the patients get an extra 10 minutes with the FCP. So, always round, it seems to make real good sense. And that's kind of how we ended up where we ended up.
Sorry,
Go on.
Chris, can you just go back?
Yeah.
Go back. This one. So one of the things that we found, and I think you guys will probably, and for those of you that are not part of Pure, all from First Contact Physios will do this, but where it says bridge the gap between primary and community care, that bit is really important around not destabilizing your community provider, not potentially, like taking staff, although you can't control where people want to work, and really understanding the pathways. And we'll come on to this, and I've learned this, like practices thought they were getting a physio. So they really struggled with how can a physio do it, like virtually, because we started working with Pure in the middle of COVID. So I think one of the kind of real lessons learned, and I've taken this through all of the pathways, all of the roles, is really making sure you understand the pathway. And if you are a PCN manager, you don't have to know, like if there's no shame, there's no expectation for you to know the pathway, you learn it. So you work with your clinical directors or your clinical champions, your practice manager, and you kind of, like you get your Post-it notes out and you think, okay, well, if I'm a patient and I need X, where do I go? And your practice managers will really, really help you with this. But I just want to reiterate that point around if you're going to bring any roles or any projects into play, you take the time at the beginning to map that pathway. And then when you get your role in, they'll know what to do. Otherwise it's like, oh, they need this. Oh, like, I don't know where to refer them. And so that was one of the kind of the learning. It seems so obvious and it's a little bit embarrassing, when you kind of look back and you think, oh, I didn't do that. So these are, learn from my mistakes. So sorry, carry on. So yeah, what does an FCP do, and what's the difference between FCP and physio?
Yeah, so I think really and truly it's that being that first point of contact for musculoskeletal aches and pains is really important. So in that traditional and older pathway where you'd refer in, you'd see a GP would look at you for a few minutes and say you need to see a physio. You'd then be referred into a pathway that if you've got a non-urgent referral is probably a 6 to 8 to 10 week wait. And the overall time for a patient to sort of see someone is 10, 12 weeks. And by 10, 12 weeks, you've developed all those sort of psychological worries about how severe that injury is. You've maybe had some imaging that's told you you've got something that may or may not be the cause of your pain. You've developed all those psychological worries. You maybe walk funny or your gait's funny or you've changed the way you use it. And all those secondary and tertiary layers of fear, concern, is this going to affect my job? Can I work? Is it going to be a long-term problem? Have all built up. So most physios then working in secondary care's feedback is that you've got to spend the majority of your time just getting them back to how they were when they first injured themselves before you can do any rehab. And the idea of a first contact practitioner is to, really do that thorough assessment in that first appointment and kind of work out whether they need any specialist input. Do they need imaging? Which for the majority of cases, most people don't. Do they need, just reassurance and a simple exercise program to get them on the pathway, and then they can be referred and have that wait however long it is to see secondary care, but they've already had some of their expectations met, some of their concerns managed, and they're on a pathway of rehabilitation before they start. Now, FCPs aren't going to give you a 100% individualized, all singing, all dancing program, because that isn't what we're for. We are going to give someone the basics of how to manage their condition and then refer them on for that rehab, so that when they get to a secondary care provider, they're ready to go and ready to engage with rehab. So it's usually one appointment. It's usually a maximum of two. So you might review someone if you think, well, actually, I could see them in 4 or 5 weeks and they'll be better, and we don't need to refer on to a secondary care waiting list. But it is not a course of traditional physiotherapy where they'll be seen for a period of time and rehabbed. And that is really, really key to know.
And I think that on reflection, some people got that and some people didn't. And I think that a lot of, and this is valid, you know, a lot of primary care networks have just come from a board meeting where it's like, how is it going to help me as the GP? I don't see the patient and then task me the referral when I could have done that anyway, or the person bounces back to me. So really making sure, I would say like another top tip is like, slow down in this. Don't recruit in a hurry. Make sure you really understand what the service can do and what the limitations of the service are, because it can't do everything. But I think helping to support the patient expectations. And I've been a patient of Pure Physio, so because I wanted to test it. So a really good example, if you're a manager, or it doesn't matter who you are, you know, like if you're going to procure a service and you think that you know, like you want to try before you buy. Definitely. And I think so often we just procure these services and go, oh, it doesn't work. You know, we can put our patient hats on and think, oh, okay, let's see how it can work. So you definitely see if you can try to access the service, try to get patient feedback, but be really clear on what is in and out of scope and how that will bounce back to the clinician when a referral and onwards communications need to be raised.
Yeah, so I mean, definitely at PCN at local level, most physiotherapists can't refer for scans and imaging as it stands, although that is something that I think everywhere is looking to change. It's just making sure that it works within primary care. But we can often write the full referral of what needs doing and probably have, to an extent, a better idea of what scan or what images or what on an MRI or what parts of an ultrasound or what views. And so it's really easy for a GP from a task, from a physio, can you please, you know, do you agree with my summation of this? And would you consider scanning for this? And all you've almost got to do is copy and paste what the physio's done if you agree with it. And it saves a lot of time in deciding around imaging. Same with prescriptions. We're often going to ask questions because most physios aren't prescribers at the moment. So we're going to ask questions about, you know, they're on this medication, it doesn't seem to be working, they've been trying it for X amount of time, what do you think about what's next? And that's where that relationship's going to work. Equally, you might be able to, you can often find physios, certainly within Pure, if a specific service goes, well, actually, we really think we need a physio who can prescribe, well, we can provide you with one of our physios who prescribes. If you think you need someone who's got the rights to order imaging, again, we can find that for you. We have staff who do injections, which is important as well in terms of offloading GP time. So, you know, there are a number of things, and be really clear about what your service needs and what you're asking your provider to provide. And as Tara says, it's worth taking your time to find out those things before you pick who you're going to employ or bring in.
And just on that note, there was something around lead up time. So what I've seen, and not just in Cranbrook, in other PCNs, they'll say, okay, now we want somebody to do injections. I want it like now. And it's like, you guys are not just sitting around like waiting for, you know, like for work. So really think about your lead up times. Not everything can be mobilized overnight. And one of the things Thin did say to me was, initially I was like, how many people can you give me? Because it was quite a big network. And he said, let's go with 1 FTE. I think it was across a few people because of how we did it. Let's get it right with 1, and then let's ramp up. And you don't have to do it that way, but the value is, you know, we don't have loads of people, you know, like thinking, where are we? What are we doing? This isn't working. Because depending on the culture of your network, And sometimes we want everybody to do everything all at once, but there is value in the practices that want to give them a bigger slice of the cake, and then let the people that are a bit more resistant follow through and all of the kinks have worked out, because otherwise they will prove themselves right. I told you it didn't work. And then they will opt out, not just of FCP, of lots of activities in the PCN. So really project managing it is really, really, really key.
So the main PCN that I work for in Norfolk, they started with me full-time as a one whole-time equivalent in November of 2019. And by December of 2020, we worked out all the kinks, it worked really well. They've now upped to 3 whole-time equivalents because they saw the need of it, they saw the benefit from what they could do, and they worked out how much they actually needed, and they've committed to that. So it is worth going in, working how it works for you, and then scaling up from there if it works for your patients, definitely. This just gives you a bit of an idea of sort of, this is from the CSP's guidance on what is included and what isn't included in this. It's very much a musculoskeletal focus, and you can see those exclusion criteria, and there are sort of slight differences. Like, my background is mainly with children and paediatric MSK. So the PCN I work for, we've developed that relationship, and I'm happy to see patients that are a bit younger than 14 because that's well within the scope of my practice. But the greater majority of these things, where you're thinking about women's health or neurological respiratory conditions, are not going to be appropriate for an FCP to deal with. So it is very much all that kind of musculoskeletal bits and pieces that physios are going to look after and be able to provide you with great insight for. Everyone works on these kind of patient flow processes, and there's some really good guidance on that and where it is appropriate. So that works really well. Training is often given in the mobilisation stage to the reception staff and the administrative staff, so that they understand fully what they need to do and how to do it from the get-go.
Sorry, Chris,
yeah,
can I just...
Go for it, no, go for it.
So go back to the other slide. Your inclusion and exclusion criteria, is that national?
Yes.
Or is that you? Yeah. Okay, so that
is... So that comes from the Chartered Society of Physiotherapy. That is not Pure.
Okay, so the reason I wanted to highlight that, and Chris and I were having a chat before we kind of pushed live, is networks will say, like, what, like to a provider, what do you do? And then the provider will say, what do you want? And you think, well, you're the expert, you tell me what you do. But there is, there is the JD, there is national guidance, but there is also something where you have said, there is the guidance, but then it is helpful to get to know your team, regardless of how they're sourced, because they all have, some of them may have a specialist interest. But where this is the national guidance, you can see children, how do you get around that? If the national guidance is saying X, but you're saying, well, I can do that. Yeah,
so I mean, that's about your, like any role, it's about your scope of practice and what you're trained for. So while that's the national guidance and that's what we would largely stick to, if someone has a particular scope of practice that is slightly different from that and is prepared to do it, that's a discussion you can have. So, we do have some women's health experts within our team, and they can provide a bit of a different service within FCP. So long as it's within their scope of practice, that's not a problem. This is going to suit, like anything, your bell curve is going to suit 95% of people, and there is a little bit of runoff either side. So yeah, it is about your scope of practice and knowing what your physio's particular interests are and how that can benefit your service.
Okay, cool.
So yeah, I don't know if there's any questions coming through as we go along, but
not yet. Can you mentioned training the reception team?
Yeah.
And I mean, we all have to get better at this because it's really, do you do it as how do you do it in Pure? But you do it as a webinar, you send an email. They are, like the receptionists are like gold, they're like gold, and we expect them to do so much and remember so much and keep taking time out of their day to, this is a referral pathway for this and this is that? Like, how do you guys do it?
Yeah. So, I mean, I agree with you. I think the reception and administration staff in any primary care organisation are like the glue. They literally keep everything running day to day. So it's really important that your provider takes time to embed them and make sure they understand what they're doing. So, you know, we do a talk in-person session with the reception staff during the mobilisation period to run through this kind of stuff, what the flow processes are from the national guidance, what inclusion exclusion criteria are, so that they understand from the get-go. And we understand that within the first couple of months, there's going to be some that slip through that were slightly not quite right. How do you have that feedback loop so that you, as the provider, can be going, no, that's not necessarily right for us and this is why, so that it's done in a way that helps people understand exactly what the service is. Let's be honest, it's less than 2 years old, it's brand new. And it was mobilised during COVID. So, you know, everyone's had lots of other things to think about, as well as implementing a completely new service for physiotherapy and MSK within primary care. So it does need something to be revisited. Often we'll do follow-up training sessions after sort of the first 2 or 3 months, get some feedback from the staff about how they think it's working, any roadblocks, what we can do to deal with that. So it's important you have those sort of structural things in place that are going to help embed you into that PCN. In terms of supporting our staff, things that we found work really well, we have these clinical drop-in sessions. So during everyone's lunchtime, one of the senior members of the team hosts a drop-in via Teams or whatever you use. We're obviously a disparate group of people working across the country, 150 of us, but you can get access in your lunchtime to that, where you can bring cases and discuss them through. So it might be that you're not fully sure exactly what the pathway is with the patient or what the diagnosis is, and we discuss that through with senior members of the team. Equally, at any point in the day, because we have staff who are on non-clinical days on every day of the week, if you've got a particular issue or you're concerned about something like Porter-Equina syndrome or a really acute presentation that may need to go to A&E or things like that, you can get hold of someone at any point in the day and just discuss that through for a couple of minutes. And we found that works really well for the psychological safety of our staff going into those PCNs, having that sort of ability to get hold of someone and to just discuss through something and check your thinking's right going into those environments. But also the protected time. So part of the roadmap is about having some protected CPD time within the week. So it's 1 hour, and expect that your provider is going to say to you, across the working week, your staff are going to block off 1 hour's worth of time to do their CPD, because ultimately getting through the roadmap is really, really important for being able to say you are a qualified FCP and be able to do that role in the long term.
You may come onto this and tell, and I wanted to pick up with you rotas, admin time, the length of the consultation, and how the PCN supports. You've got your support in Pure, like how it's our role. How do we support you guys?
Yeah, absolutely. So I think we will probably come on to that. So, it's basically any patient in terms of accessing any patient who's registered. They don't have to speak to a doctor first. And that is probably the biggest change away in primary care, isn't it? That we've had this model for a long time of you need to see a doctor to make decisions. And that's really, certainly MSKs, your FCP physio should be your first point of call. And it offloads your sort of nurse practitioners as well to do other roles within sort of the PCN. In terms of, this is kind of what you can expect an FCP to do in terms of what they provide. So that real kind of specialist assessment around screening and serious medical conditions, red flagging, and sort of doing general red flags, part of your make every consultation count. We can give information on self-care and enable behaviour change, a whole range of things around sort of personal exercise, fitness for work. Obviously that's come in over the last couple of years with AHPs being able to write fitness for work documents. not every employer will accept it if it's not from a GP, but actually, and they don't have to legally, but actually quite a lot will. And that's another way physios can offload time from the GPs. Obviously, we sit within that social prescribing pool. So one of the people we work closest with within the PCN team is that social prescriber, and working out ways to do, we might do the targeted exercise management for a particular condition, but also that global discussion around physical activity and health, smoking cessation, weight management, how do you adhere to the physical activity guidelines, which we're definitely going to come on to later, referrals for the relevant MSK, things like the dietary and secondary care physio, and then referrals onto those bigger services. So
can I just say, if you are from a PCN, like take a picture of this, like if you're going to take a picture of any slide, take a picture of this slide if you're, and just keep reiterating it, put it in, really over promote. This is how this particular role can support the network, because I think sometimes we're a bit too vague. And I think this provides kind of a bit more specific around the tasks and activities. So I think that's really helpful.
Yeah, and this is where physios can save GPs time. There is no doubt that FCPs and first contact practitioners can save your GPs time in these areas particularly, as well as other bits and pieces as well. So some patient feedback, the embedding. So this will cover how the PCNs can support their physios as well. So there's a lot of plan, do and review. We audit, every physio audits the time spent, and we give particular feedback each month. So we just store the data of what we do and then feed it back to the PCNs each month. So you've got this nice intro slide, how many consultations we did, in terms of equating how many GP hours is that saved based on an equation of sort of time used and what GPs normally do within that time. How, what we think of those key stats of percentage using the FCP service that did not require additional GP care. So, you can see there for that 1 month in February, almost 95% of the people that we saw didn't need to see a GP at all as part of their initial management. And that's really, really key. Also things like imaging and injection, you've got less than 5% of people needing imaging and injection. And when I did an audit for this PCN particularly that I worked for in my first month I was there, across 1 week, they asked me to look at where people had investigations before they'd seen the FCP and whether the FCP thought they were relevant or would have ordered them or asked the GP to order them. We equated that to around £4,000 to £5,000 of what we would deem as potentially unnecessary imaging that didn't advance the care of the patient, or the physio wouldn't have ordered if they'd have assessed them first. If you're talking at £4,000 a week for one person, and there's 150 at Pure and X amount other providers around the country, we are talking in the millions of saved money in imaging for the NHS just by having that physio assess them first and do the reassurance. And it's a difficult demographic for GPs. GPs have to have a really long-term relationship with their patients, and they have to be able to, the patients have that bond of trust that they can go to the GP. When you then pass it out to specialist providers like ourselves in musculoskeletal care, we don't have to have such a close long-term relationship. We can be a bit harder with people in terms of saying, well, look, imaging here isn't going to advance what we do, and therefore, do we really, really need it? Or can we try and push a message of self-management rather than injecting something that's just acutely painful? So there's lots and lots of bits we can do there. And also you get lots of nice demographic data. So we can find out who's purely using FCP. So if they are reception triaged or they phone up and say, I want to speak to the physiotherapist because they know the service is there, that is true FCP, not needing to use anyone within the GP team. You can see there's still a percentage of, we're still always working out, what patients are appropriate. So some might end up with the GP, and that might be a good shot. And then the GP thinks they need to see the FCP and refers them across. And that might be a good statistic to show that you need more FCP provision because you're using all your FCP slots and the GPs are still seeing a volume of sort of musculoskeletal patients. And then all those other stat breakdowns around sort of telephone initials and face-to-face and what percentage of which, also looking at locations, what type of area of the body we're seeing, your common favourites are lumbar, knee and shoulder, and then how many and what percentage of patients could be self-managed and all of those kind of things. So it gives you a real good reflection of what your patient demographics are, so you can do those trends over a long period of time and work out. We then give some summary statements at the end of each month, and we're now at the point where we're doing annual reviews where we can show what we're doing and how we're impacting what we do in primary care.
Chris, can I ask, where do you get that data from?
So we use an online tracker, which takes about 6 to 10 seconds for the FCP to input through the day. So they can do it, they can choose to do it after each consultation if there's time, or because we have admin breaks at different points throughout the day, you can do it in that time as well. It's really, really helpful for us, one, working with our individual staff, and because we can do that data for each individual, we can help to see what they're using, what services they're using, and help improve the individual that way. But also for a PCN, see what services are being used and understand what pathways need tightening or enhancing or whatever. So it's a real useful tool for helping PCNs see how to improve the musculoskeletal health of their patients.
It might just be worth flagging that we've had experience where PCN doesn't believe the data, so patients will be unhappy, and obviously they will make that known to the practice manager or the receptionist, and that it is what it is. And then we see the data and we place more emphasis on maybe the few patients that weren't happy versus the data. So I think one of my kind of plea and what I have learned is, when you, regardless of the role, but when you get your data through, is to block out some time at the end of the month to look at all of your services and do a bit of a service review. Look at that service utilization, whatever data you collect, whether you've got Ardens, whether you've got Apex, you'll be able to provide some analysis. And then if you're using a service provider, or even if it's your employed roles, is to have if there are issues, you want to address them ASAP. But if it's all running smoothly, maybe you have a quarterly review, or just say to the role or the provider, things are all going well. What tends to happen is we wait, if we're not happy, we don't say anything, we all grumble behind your person's or team's back, and then something will come to a head where a lot of these things could have been addressed if we had looked at the data, looked at the utilization, and worked out what is the metric that is really important to us. So I think that's just a lesson learned.
Yeah, and I think this next bit is sort of being part of PCN's life. So understanding where you fit within the ecology of that PCN, making sure that you're involved. So if there are daily meetings or weekly or monthly meetings, making sure that the physios and the FCPs are invited, ask them to present the data, ask them, give mutual feedback around what's going well on your end, what do we think is going well on our end, do we have some shared concerns or barriers that are developing, and how do we get ahead of them early, rather than, like you say, if you've got a contractor in and they're not sort of fully embedded and don't feel part of the team, then things can snowball into bigger issues that don't need to be. And that's why we really encourage our staff and the guys who run PCNs to get involved on all those different meetings, so that we can nip things in the bud and find out, because it's an experiential thing when you launch a new service, make sure that everyone's happy and what we can do to identify those issues and improve them ahead of time before they become big issues.
On that, can I just say, in the R staff that got a clinical role, where you've got, like a diary, got your appointment slots, it's coming quite hard to negotiate which meetings you go to. You've got your own clinical supervision. And I think that what I've seen first time with all of the roles, every meeting you attend, you take away a clinical slot. And that tension is quite hard to manage. So you want to set your, and it goes back to maybe your workforce strategy PCNs around all of the roles. You know, what are the principles for our team moving forward? They all come to, you know, like a couple of important meetings. They have a WhatsApp group. It's how do you embed them? And once your network gets used to that, when you say, or the network will say, or the role will say, I've got this meeting, it's fine and it's accepted. I know some of you will be thinking, well, that's a no-brainer, but it's not that in every network. You kind of have to negotiate. We had, you know, the amount of negotiation we had to, you know, do for an admin slot was a lot. So again, just things to think about if you're not already there.
But equally within our structure, you'll have sort of people like Richard, who's a regional lead, Tom, who's our national operations manager, and they may well sit in some of the bigger meetings having feedback from us that they'll feedback. And then there's no cost of clinical time to the team lead. It doesn't always have to be that team lead who's presenting. You know, there are structures, higher structures that allow people to not affect the clinical time and still get that embedding and making sure that everything's running well. So yeah, that's definitely important. I think, you know, we as a company, Pure, what we try and do is add value by, we produce these weekly bulletins. So we pick up new research as it's published, things that we think are relevant for primary care. We'll do a write-up of these bulletins and we'll send them to all the primary care staff that's relevant. So we've had some really good feedback from doctors and nurse practitioners and other members of the team, not necessarily something that they're going to use every day, but just widening that understanding that things have changed. So, you know, one of our big things is around osteoarthritis and the advice that's typically given when someone's diagnosed first with osteoarthritis around stopping meaningful activities like running and those kind of activities, because they might make the joints worse. The evidence just isn't there for that. You know, the evidence is that you should promote physical activity and stay fit and active, because actually that promotes joint health. You're much more likely to develop OA in your knee if you're sedentary than if you're an active runner. So, you know, it's trying to help upskill our staff and our wider staff within the PCN as well by things like those bulletins, because it's unhelpful if someone's telling you to stop and then you go and see the physio who gives you a completely different message. So those sort of things are really important. We're really lucky at Pure. We've developed this an excellent website with patient self-help tools where they can go and do some learning, evidence-based learning about their condition. And it's where we give most of our sort of basic exercise management from. So we use that all the time. And that's a resource that all the staff can access within the PCN, not just the patient. So it's kind of a real helpful resource both ways, and we'll see a little bit more of that in a minute.
Sorry, Chris, just to go back, one of the things we did in Cranbrook, which I'm really proud of, is that we set up education sessions. And the principle around that was, let's utilise the expertise of our team versus always getting in, you know, like external speakers. So the kind of premise was each of the roles would deliver a session on their specialist interest or something they've just learned or more about their role to the rest of the network. And that was when, from a FCP perspective for me, like the penny dropped. I was like, okay, that's what the FCP does. And you also gave me or us lifestyle advice. So that was really, really good. So that's a quick one. That was really helpful. Even Valentina, you showed us this it's like a picture of, you know, the amount of exercise that you could do. And even, I think, I don't know if she's still on the call, but Valentina was like, she took a picture. She was like, right, I'm going to do this. So I think just asking your team to share what they know is a really good way to get to know people. We did it like this as like a Teams session, and we recorded it and put it in the newsletter. And the goal is for everybody to, you know, like to dip in and come in. And I think that's a really good way to help all of the roles, because they all sometimes not overlap, but we employ the team, but we don't all know what each other does. So that was really helpful, and I will try to embed that in all of the PCNs I work in.
Yeah, so the really helpful session one of the pharmacists in Cranbrook did on COPD was massive for me. I learned loads out of it, and it was really helpful for me when I came across those patients who might need a review knowing how to then refer them in for those things or recognize the signs that they need a review. So it was really, really helpful for me. And then being able to do this session or a similar session back again was helpful in them in Cranbrook sort of understanding what we were doing and why we were doing it. So you've got simple things like red flag screening, and we produced our own stuff. So these are both digital and printed cards that we can give to patients and say, look, if your lower back pain signs and symptoms change, refer to this card, and if something changes that's on this card, then come back to someone. So it's an easy way of sort of safety netting patients to better understand where we are and do those screenings of sort of general red flags around weight loss and feverishness and unwellness and all those kind of things that are really important to pull out the masqueraders that look like musculoskeletal pain. This is a really good one. This has even changed since I presented it to you guys, because the physical activity guidelines haven't changed. They are there, really easy to understand. Range of health benefits in the purple at the top. The green talks about your cardiovascular stuff, whether it's light or moderate or more intense. I play basketball for 2 hours on a Monday night, and that covers my kind of cardiovascular fitness. Lots of people choose to briskly walk their dog 5 times a week for half an hour or go out with a friend. That also covers it just as well. But it's that red bit in the middle that most people miss. It's that strengthening, doing targeted lifting that is outside of your work, because doing it within your work, as you'll see in a minute, doesn't really count. And I would quotient that, if you're doing the red and the green, you're minimizing your sedentary time, breaking it up really well. And for older adults, there's something around sort of balance, simple activities and balance and online videos that they can do as well. But even now, like this paper came out sort of less than 2 weeks ago, showing that actually when you independently look at these things, muscle strengthening activities are associated with lower risk of mortality in these major diseases, type 2 diabetes, cardiovascular disease, joint and back pain, all those other things. So actually, if you're going to target anything, it's the strengthening work's probably more important than the cardiovascular work. Now that sings to my biases as a physio, but that's not something that we would have even known 2 or 3 weeks ago. So that knowledge is always changing, and it's why it's important we do these regular feedbacks so that we can keep people up to date with what new knowledge is. So you've then got things like the physical activity paradox, and this is nice and easy to explain to patients who go, well, I do a manual job and I go to work all day, surely that's enough. I'm absolutely knackered come 5 o'clock when I've been on the building site all day or done whatever. But there just isn't the evidence for work, physical activity, inferring those same health benefits as doing it in your leisure time. So it's really easy to get hold of those, and most physios will have these resources to hand to be able to share. It's easy with things like System 1 and EMIS now to be able to just email them off to the patient so that they can get hold of them or print them out in the clinic depending on what they need. This is our website, so we've got this really helpful self-help guide where you can find the different conditions for you. You can read about them, so it's broken down into really helpful evidence-based sections. And then there's some basic rehabilitation plans that give you some guidance as to how hard to work and what you should be feeling while you work. And this is sort of an example of a back pain one that will get a patient started with their rehab journey. So, they're useful things that physios can bring to the table. And then it's knowing your evidence. This is a really well-held piece of evidence around corticosteroid injection versus wait and see in physiotherapy for lateral epicondylalgia or tennis elbow, showing that yes, corticosteroid injection will reduce pain very effectively in the initial stages, but actually in terms of the long-term overall patient thought success, PFG, which is sort of patient grip strength, shows that actually physiotherapy and conservative care without the injection is far more effective and statistically significantly more effective in the long term. So primary care's approach has often been to inject things early, when actually the emerging evidence shows that conservative care, reassurance, lifestyle stuff and strengthening is actually better in the long term. You find that not just across lateral epicondylalgia, there's a range of things around things like lateral hip pain or greater trochanteric tendinopathy or gluteal tendinopathy, whatever you refer it to. Again, showing the same sort of things, that education and exercise is more effective in the long term than just injecting something. So, it's not to say that corticosteroid injections don't have their place, because we know there's a percentage of patients that won't respond to conservative care, but let's try and do that first because of the negative effects that come with injections.
Okay, so we've got just coming up to 25 minutes past. So we've got a question. Sorry if I missed this, but how does the PCN support training learning needs for FCP, but how does the PCN support training learning needs for FCP in practice? What is this typically?
Yeah, so I mean, that obviously will differ from provider to provider. How Pure does it is we do the 1 hour of protected time per week, and we give a range of stuff for the staff to work through towards their roadmap. So reflections on clinical cases, they might be clinically observed by a member of the team, but we also do national CPD days. So 5 times a year, a full day out of clinic is supported by the PCN for us to do extended learning. So we will provide those learning needs around what our physios need to be good primary care practitioners. So it's largely in terms of time. There are some mentorship things. So if you're your physiotherapist, you want them to learn to do their prescribing or their injecting, there might well be some mentorship needs there that GPs and other members of the team can do. And other than that, it's more about supporting time, certainly in the way that Pure does it, than anything else. And I think that would be the same for a lot of providers.
Okay, how many appointments on average do you have per day?
Yeah, absolutely. So the way that Pure works it is you work sort of in standardly an 8.5 hour day, and you would see 20 patients within that day. So 20-minute appointments. So the way most people work it is you'll see 6 patients, you'll have a 20-minute admin slot, you'll see another 6, you'll have an admin slot plus lunch, and then you'll see 3 admin slot, 3 admin slot to finish off your day, and that makes you 20. 6, 6, 4, 4, sorry, in the afternoon. It can vary depending on a member of staff. Sometimes they do long days, so you might get someone who's in for 10 hours. They would obviously more, but a standard 8.5 hour day equates to 20-minute patient contacts.
Okay, so Claire is just going back to that. That was, anything longer than a 10-minute appointment initially was very hard to sell, and the admin appointment. It was like they get 20 minutes and admin, and they want a lunch break, and they want training. Like it's like, I want to be an FCP. So we had that. I had that to manage. And Claire is asking, if we have an MSK role within a PCN, do you support? Does Pure Support provide support and training
for the member of staff or for the PCN?
Yeah, I suppose both, really.
Yeah, so I mean, absolutely. For the member of staff, Pure supports all the training needs really that they have around the roadmap and making sure we're accredited in the right way. And obviously, we've talked about doing those training sessions for the staff in terms of making sure reception and admin staff are happy with it. We're also happy to do training for the staff, as as how we met doing this with Cranbrook around the different roles. So yeah, we're happy to do kind of work with the PCN, any PCN and their needs.
Do you have a training arm? So do you only get that if you're like part of Pure, or could somebody else that doesn't have a Pure FCP, if they want just your expertise, can they somehow access your service without having the Pure member of staff?
I don't think so. No, I don't think that because we're putting what we know our needs are for the staff we work with onto someone else who might have totally different needs, and we've got no way of ensuring that.
I think HEE provide lots of support, and I think lots of training hubs provide support. So it depends on where you know, like how developed your training hub is. But my first port of call, I mean, for everything is HEE. They're my training hubs, and then I'll just canvas, you know, like I'd pop into like a PCN Managers WhatsApp and say, what do you use for X or what do you use for Y?
Yeah, so I think, you know, the HEE and the websites there at the bottom of those first sentences, that is pretty much the one-stop shop for if you're interested in an FCP role and how it should work and what you can expect from it. There is obviously this document, the First Contact Practitioners Roadmap to Practice from July 2021. That's a 120-page document, so do prepare yourself for some time to read it. And then there are all these other things. So, you know, NHS England looking after your team, do some mentoring for FCPs, and that's a free to access nationally funded service. And you'll find lots of webinars and free resources turning up. So this is ACPO's webinar on work and health, the practical use of the sort of fitness report. So, you know, there's lots of different bits cropping up that are both nationally run and run by particular physiotherapy interest groups to help FCPs get better at the roles they're trying to do. So there's lots of support out there, both internally within an organisation and externally from a national point of view. The advantage of taking a larger provider, someone like Pure, is, you know, we have 150 staff who can all access each other at any time. We obviously have an understanding of these roles because we've been doing it for sort of 4 or 5 years before it was funded as an FCP role. Those roles still existed. So we've got lots and lots of experience, and, you know, we're well au fait with the roadmap, and we've got lots of educators within the roadmap. So you don't need to provide your own FCP educator because we have them, and we support our staff in that way. So, you know, you can see all those sort of bits and pieces of what you have.
Okay, we've got
We're almost done.
Close to time. So Sarah's asked, are your costs higher than the R's we can claim? My experience, go on.
No, go on, Tara, you go.
I was going to say no.
No, absolutely. I think
they will operate within the envelope.
Yeah, so there is a discussion around how much you want. So yes, it can fit completely within your R's funding, or if you want a little bit more and you want more hours out of it, you can pay top up out of a PCN's profits to get a little bit more. So, but yes, you know, you can get FCPs within the R's funding completely.
Can I just say though, Sarah, I saw a message yesterday where it said, you know, if you do the R's claim, you have to provide the breakdown of, you know, like PAYE and national insurance. So that may change, you know, like we can't claim 1 FTE if we're not getting 1 FTE. Do you know what I mean? 1 FTE. So we do need to go. I hope you found this helpful. My last parting bit of advice is that I would have a clinical champion, which is not the CD. I really, really would, just because the CD is so busy. The CD is a champion for like everything. If you can have it, and they don't have to be a GP, but have a clinical lead that is going to work alongside the manager, the practice managers, to really scope out what you need, to understand what's in scope, what's out of scope, and make sure you have, you know, like your monthly meetings. And as things start to settle down, you can, you know, you may not have to review it monthly, but I would definitely do that. And we'll send everybody the slides that has come to this session. And yeah, I hope that you liked it.
And if you want to talk to us on the back of it and get some advice, you know, myself or Finn or Tom Beadle, I'm sure Tara can link you in with them if you want to do that.
Cool. Thanks, guys.
Thanks.